share my screen. Okay, so probably our first job for tonight is to really define what is meant by abnormal behavior and mental processes, or what we broadly call abnormal psychology. Okay. And, if you want to look at the most basic definition, it's anything that deviates from normal. But then we have to ask ourselves, what is normal versus abnormal? Okay. And there's really three ways that both individually and communities and in broader cultures, we define what we consider to be abnormal for a given uh, person's versus not. And it's really important to keep this in mind as we bring up some examples of, for example, different cultures and how they view abnormality versus non-abnormality. But let's kind of go through let's kind of go through and just talk about three perspectives. One is the individual perspective, which is called the egocentric perspective, which kind of goes something like this. I myself have experienced abnormality, normality. I'm an observer of the world, and so my personal experience guides what I see in the world as normal versus abnormal. Okay, so a really maybe a clear example of this is anything that someone does that I would not do would be abnormal. That's not how things should be done. And this is the egocentric perspective of defining what is normal versus abnormal. Okay. And it's really, when it comes to these kind of academic discussions on this, it is one of those mental humps that a lot of students and even professionals kind of have to overcome because our egocentric view is largely reinforced by what are known as social norms and by cultural, if we want to use norms, beliefs, and ideas. Okay. Social norms is when we use our immediate social world to determine what is normal versus abnormal. Okay. So, for example, a common social norm is someone's religion or their spirituality. And within the guise of religion and spirituality, anyone who doesn't believe in that system of thought can be seen as abnormal. Now that's a general statement. I don't want you, it's and an example. I don't want you to think all religious people are like that or all spiritual people are like that, but it's an example of using a social norm, a belief system, a way of behaving in the world that then determines anyone that doesn't fit within that scope must be abnormal. Okay. If we would have done the social psychology section, we would have talked about in groups versus out groups. In groups are those people who are like us, like me, and who I affiliate with, and who I get along with, and who I feel a sense of belonging with. Anyone that doesn't fit within that group context is an out group. And in that, we tend to see people in out groups as having more abnormality than people in our in group. Okay. We also, in using social norms, think that our in group tends to be more diverse, more independent of each other, where out groups, they all think the same. They all are the same type of person. And then this guides us to a belief of what's normal and abnormal. So that's social norms, using our immediate social world, immediate belief systems to say this person is abnormal because they don't meet within my social repertoire of definition. Okay. And then the last one is our more cultural view. Okay. Our more cultural view is how culture determines what is normal versus abnormal. Okay. In this, we can bring up what are called gender norms. While a lot of individuals claim not to hold on to the traditional men, female, man, woman dichotomy, and men not being allowed to be emotional and women being overly emotional, quote unquote, we actually still hold those cultural precedences. Okay. So, from a Western cultural perspective, many individuals within our culture assume that a man who is expressing their emotions very strongly, they must be abnormal or something's wrong with them. Okay. When a woman in the Western culture, especially in the United States, is dominating and is strong, kind of more of those quote unquote masculine type of traits, they're seen as abnormal. Other cultural traits is again going down the gender rabbit hole. Men are seen as stud for having several intimate partners, where whereas women are seen as please, if you have kids in the room, I'll just spell it out, are seen as SLUTs for having several intimate partners. Okay. And those are just some gender examples. We can even talk about how do we define mental illness that step further into abnormality. Okay. And we can see, for example, what is considered a mental illness in one culture is not necessarily considered a mental illness in another culture. And we'll use the example of attention deficit hyperactivity disorder in this approach. Here in the United States, ADHD is seen as a mental disorder of the individual child or adult. Okay. And so we treat it with medications, we treat it with um, uh, therapy, all of those different things. In France, ADHD is not seen as a mental disorder. It is seen as a dysfunction within the social and family system. So, a child in France, if they're having attention deficit hyperactivity issues, they don't go and get put on a medication and all these things. No, first, reconstruction of the family system, working with the parents, working with the school. Very little actually is done with the child. They try to repair the social system around the child. Okay. Um, and whenever I bring this up, this is a very difficult topic for a lot of American parents who have children with ADHD because we see it as a disorder. And how could they then not treat a child in France, who probably could, from our again cultural egocentric perspective, would benefit from medication or benefit from something of more of a medical treatment? Well, we actually find that treatment rates between the two countries um, are very different. And we'll get to that when we get to ADHD, which I think might surprise many of us. Going beyond mental illness, but probably just as significant, we can also look at psychopathic serial killers. Okay. If you looked at psychopathic serial killers, tend to be what's called a Western phenomenon. And if we have more time, we'll go into this more in depth. But you will not find, for example, a case of a psychopathic serial killer pre-colonial times here in the Americas. You won't find a serial killer in the Eastern lands, such as Asia, India, and the um, non traditionally non-westernized countries until recently, until we get into the 1970s and 1980s when there was a push to westernize Eastern culture. And this is where we started to see the development of psychopathology, one, and then serial killing, second. Okay. So in this I want to use as an example of how culture and acculturation can really influence our perspective on what we call abnormal psychology. Okay, so these are kind of the three kind of ways that we look at it, but how can we view it from a scientific perspective? Well, nothing is that can be put into studies scientifically in this area without uh, um, looking at the influence of culture, which we will get to here in just a couple minutes. But I want to make it clear that even within the field of clinical psychology, even when you're looking at pure researching, you will always have these three influences on individuals. And I'll bring this up as a final example. If I gave everyone the same list of symptoms and I had you go to a different provider and give that provider the symptoms, how many people do we have in our class right now? Right now, we have, not including me, we have 20 students in the class right at this moment. I am willing to bet that the majority, probably 15, will come back with a different diagnosis based upon the clinical experience and the experience of the person I send you to. Okay. And so the other aspect of this is that, and I want to make this clear, this is not a perfect science. And I hope that clinical example kind of elucidates that. But we'll get more into that as we move along. Okay. Now, what is one way we can, if we can measure abnormal behavior? Okay. Well, we can if we're able to measure it through some type of survey, some type of measurement device. We know that any behavior, if we measure it enough, will develop what's called the bell curve. Okay. And if you want to think about it, anything under this kind of orange reddish line represents somebody, a person of some type. Okay. And in this bell curve, we have what's called the mean, also known as the average, where 50% of people either will score higher than that number or lower than that number, okay, or that score of some type, all right? When we get out, though, we have something called standard deviations. The first standard deviation represents about 77% of a population. The second deviation represents 95% of people. So if we were to draw this, let's use this line here. If we were to draw this, everyone underneath here would represent 95% of people, okay? 5% would score above that mark and 5% would score below that mark. Okay. If we're measuring something, for example, sadness, maybe we would have extremely sad on this side, but extremely happy on this side. Okay. So here is where clinical psychologists would become interested in. We want to know what is making that 5% sadder than the other 95% of the population, or 95% of the population. Positive psychologists, which has been a field for about 25 years now, it started in 1999, They were tired of us always just focusing on the negative aspect of the human condition, the clinical aspects. So that they developed what's called the study of positive psychology. And what they want to know is what makes 5% of some people happier than 95%? What makes 5% more motivated than the other 95%? They want to know what makes it about the 5% that makes them more satisfied in life than the other 95%. So they want to look at it from the other direction. Okay. So this is how it can be defined when it is something that we can measure within a population. Okay. And here in a minute, this is what is known in Western terms, how we diagnose, and we'll go over this guide, is the Diagnostic and Statistical Manual of the American Psychological Association. And this is kind of the statistical part of this, is determining what conditions statistically are present when a person is experiencing something like this. Okay, so this is another approach, is looking at those fringe, but this requires, again, measurement, which I hope by now might not always capture what we need to capture when it comes to somebody suffering from something. Okay, so the other difficult thing about defining abnormality is that we all will experience forms of abnormality throughout our life. Okay. We all will experience sadness. I hope I've already impressed on all of you. We hallucinate every time we have our eyes open. Um, let's see, what are some of these other things? We all will go through periods of irregular sleep. I hope it's not harmful, but believe it or not, we've all experienced violence. I know this sounds strange, but if you were alive between the age of 3 and 6, you were probably kicked by a brother, sister, or a peer, or uh, shoved, or slapped, or something. Okay, we don't consider that violence because it doesn't hurt, but technically that was violence. Okay, we will all experience self-depressed moods, thoughts of harm, all of these things. But what makes these something that may not need intervention? Okay. Meaning, should we get intervention every time we have a moment of aggression? Or should we go get our blind spots in our visual field corrected? What about depressed mood? Every time we experience something that depresses our mood, should we go get treatment from our doctor or something? Okay. And that's a question of debate. Okay. But let's,
Wait till I go to follow it right now.
okay.
Makes me laugh. But yeah,
All right. Before we move on further into this lecture, I do want to make something clear. I'm willing to bet, because there is 20 of us. Some of us may have been diagnosed with a mental illness or may be currently getting treatment for a mental illness of the like. Okay. This lecture is an academic lecture. Okay. If you are being treated for some disorder, especially with a biological drug of some type, if you're receiving some type of treatment and you're going along in this lecture and you're kind of questioning that, do not stop your treatment. Have that conversation with your provider. Okay. No one should feel like, just because of this academic conversation, that they should immediately stop treatment or immediately stop seeing a provider or a counselor. That is not the message that needs to be sent with this lecture. So I just wanted to put up the warning, the caution, before we move on. So the next thing that we need to ask is what's the difference between, for example, mental health and mental illness? Okay. And later on, when we get to health psychology, we'll actually look at this a little bit more closer about things like psychological states and how do they influence our mental health. We're going to leave this up for health psychology and that topic, but I do want to just spend a moment and rehearse what is the difference between mental health and mental illness. Okay. And I like to use the example of physical health and physical illness. Okay. Um, we can be physically healthy. We can eat the right things. We can exercise. We can do everything right, but we can still have a heart attack. We can still end up getting diabetes. In the same guys, we can have the worst diet in the world, a very sedentary lifestyle, very unactive, and we may not get diabetes or a heart disease. Okay. And this is an important thing to state. Mental health, poor mental health, just like poor physical health, can increase the probability and chances of getting a physical disorder like diabetes or heart disease or cancer. Okay, definitely can increase the chance. Same with having poor mental health. Poor mental health being you don't pay attention to your social world. You don't engage in healthy relationships with other people. That's one aspect. Other aspect is you don't exercise your mind, your brain through studying or through hobbies or through activities that engage the brain into thinking. And then the other part is of mental health is not paying attention to your emotional world, letting your emotions rule your day instead of giving emotions the rules to say, this is when you can control me and when you can't. Okay. That's what we're defining as poor mental health or what leads to poor mental health. And that can lead to the probability of definitely getting a mental illness of some type. But it can sometimes, just like with physical health, only be part of the equation. Okay. The other thing that it's important to distinguish between mental health and mental illness is that when we look at some abnormal behaviors that people commit, it a lot of times deals with very, very poor mental health, but there's no diagnosable mental illness. And probably the best example of this is mass school shootings. Okay. When we've investigated mass shootings for what we can investigate with, we find that is there in most cases a diagnosable mental disorder? And the answer is in the mass majority of the cases that have been reviewed, no. None of them would have qualified for a diagnosis of a mental illness that would need serious medical and psychological treatment. Okay. What we do find is that they have very poor mental health. They often have been bullied, social isolated, that they engage in single thought processes and very closed-minded ways. They tend to be rejected a lot by their family and left alone a lot of the time. And so very poor mental health, but not necessarily a mental illness. Okay. So I just want to bring that about because, and the important reason to bring this idea about is if it's a mental health issue, it's much easier to stop. There's no reason we should have gun shootings, mass shootings in schools, because it's not an illness that's driving those mass shootings. It is the social and psychological constructs within that person's environment that, if we paid attention to and worked with that youth or that adult, those things probably would have never happened. Okay. So that's why, from as psychologists, we say that yes, mass gun shootings in schools are completely um, preventable if we have the right tools in place. Anyways, I just wanted to emphasize that point. But also, there's other mental health issues that are driven by mental health that also develop into abnormal behaviors. Okay, things such as excessive drinking, excessive pleasure seeking, excessive things that are harmful to an individual, again, may not be harm, not may not um, are mainly driven more by mental health issues than a mental illness, as you would say. Okay, so I just wanted to bring that up as an important criteria when we look at, when we see abnormal behaviors and we start to give them labels. We need to be very careful about uh, labeling something a mental health issue versus a mental illness issue. Okay. The other aspect, so now let's go into defining what a mental disorder is. And again, we're going to use the Western kind of version of this. Um, this definition right here that you can read if you'd like comes directly out of the DSM, okay, which is that diagnostic statistics manual that I mentioned, okay. Um, but what I want to focus on in for our sake is this left panel, okay. And the first component is that what I want to talk about is a cluster of abnormal behaviors, okay. Mental illnesses is a cluster of these things. Okay. So, for example, a person who constantly feels sad, they have irregular sleep issues, they have depressed moods, they have thoughts of harm. We may see that there's certain populations where these abnormal behaviors cluster together. Okay. And maybe in this case, I'm using a depressed mood example. Maybe what we define this is as depression. Okay. And as you will see as we go through the different disorders, there's different patterns of abnormal behaviors that people have that give a way to the disordered behavior that we'll be discussing. Okay. But going back to our definition, so it's a cluster of abnormal behaviors that are what are considered deviant, distressful, and persistent over time. Okay. Deviant means that the individual themselves know that something's not right, that one day or over a series of a day, all of a sudden they just didn't want to get out of bed, or they just can't at certain times control all the thoughts that are going on in their head. They don't have control over them in some way. When we look at substance use disorders, they recognize that their drinking or their substance use is not within kind of that normal, I drink to party or relax in the evening, but it's something I need. It's a need, and that therefore deviant. Okay. The second thing is it causes some level of distress to the individual, and in some disorders, we can also say cause distress to the family unit or social system. Okay, some example of this is a child, especially a young child with ADHD or autism. They might not think that their behaviors are deviant or distressful. but they might be distressful and deviant to the parents or to the school teacher or to the social system. Okay. And so distress, but in most cases, even with a lot of young children, they recognize that I can't sit down and do my work like the rest of the kids. And I'm constantly, for example, being made fun of or told to sit still. And that causes distress. Okay. And then the third one is persistent over time. And this one is important because, for example, some disorders, um, symptoms of disorders, I'm going to use the word symptoms of disorders, can come to an individual because of some life event, but it will naturally evade itself. Okay, a good example of this is depression from the loss of a loved one, or there's something that when you graduate from college, it's very common for college graduates to experience depression about a month after graduation and for a couple months into that. Okay. Most depressive symptoms, about 90% of depressive symptoms abates themselves after about 90 days. Okay. So you wouldn't necessarily consider that kind of a disordered behavior. That's kind of normal to experience those kinds of things for a temporary purpose. Same thing with, for example, anxiety. If you lose your job, there was another example of people who, well, another very clear example is people who use drugs. They will definitely, if it's a narcotic such as cocaine or methamphetamine, they will develop schizophrenic symptoms. And so, but those are short lived, they're short abated experiences. Okay. And then, of course, the most important and what really should drive our decisions to whether or not this should be something we need serious intervention for, despite all of these other three, is that what the person is experiencing is maladaptive. Okay. So, for example, a person with such severe depression, they can't get out of bed to go to work. They start to ignore family obligations. They start being really late with getting stuff done if they even get it done at all. And all of those things. So the cluster of these abnormal behaviors become to such a state that the person starts to fail to survive or thrive. So they can't keep with. So, for example, they lose social ties. Oh, I just lost my train of thought. Unable to function in their occupation or do or engage in important human activities that we would all normally, well, not all of us, but a good normal of us would, such as going to work, going to activities with family, those types of things. Okay. So this is how the Diagnostic and Statistical Manual of the American Psychiatric Association defines a mental disorder as. Okay. Um, Now, I did kind of want to mention before we go on to look at some other definitions that are important and other considerations to important is I want to go back to what I stated in the first of class. Okay, is that these are very much, while they try to use statistics and clinical evidence and all of these things, these do tend to also have a large cultural influence. Okay. And using the DSM as an example is important because when, for example, in the 1990s, when we went from version 3 to version 4, um, uh, uh, homosexuality, being gay and lesbian, was no longer considered a mental illness. However, before the 1990, I think it was 97 that the DSM-4 came out, you could be clinically diagnosed with the mental disorder of homosexuality that then could potentially make you not eligible for certain types of works in certain type of states, require you to go through some type of treatment to continue benefits through your insurance company or through the social welfare system. Okay. But in I think it was 97 when they went from DSM-3 to DSM-4, they decided to take that out. Okay. But it wasn't because of neurological evidence. It wasn't because of clinical evidence that they did this. It was because of the changing perceptions of what it meant to be homosexual. Okay. And the decision to take it out of the DSM was a vote. They basically pulled all the psychiatrists that were contributing to the DSM that year and said, should this be a disorder or not? And the majority won that vote. It was a kind of a democratic decision to take it out, not necessarily an ethical or clinical or neurologically based or biologically based decision at all. It was a democratic. My personal perception of this is that it is not a disorder or it is. Um, in 2000, I think 10, Asperger's was taken out of the DSM 4 going into DSM 5 because the change in perception is that that disorder is a milder version of autism. So it went into the autistic diagnosis, and that Asperger's was taken out of the diagnosis manual, which caused a lot of upheaval socially because from one day to the next, all of a sudden a child woke up and they didn't have a disorder anymore. And because they didn't have a disorder, they didn't have a treatment for that child. And so then again, they had to go be reassessed under the new guidelines of what is autism and autism spectrum, and then draw up a new treatment plan, draw up a new identity of what's driving the abnormal behaviors within those children and adolescents. Okay. My point being, I just want to focus on this is that, again, this is not an exact science. While we've made strides and whatnot, I just want everyone to keep in mind this is not the most perfect system that we have in defining what is a mental illness and what is not. Okay. Um, we've talked about this, and I won't focus too much on this, but these are those three dimensions of of mental health and physical health. So you can take a look at this and kind of go, okay, this is what he meant by mental health versus physical health at another time. But I won't push that topic much further right at the moment. Okay. Okay. I'm going to come back to this, I promise. But that conversation is going to take a little bit longer than what we have. So, you know what? I actually am thinking, let's go ahead and stop right here because it would be good to do the trauma conversation and then the conversation on historical notions of mental illness kind of together. Yeah, I think that would be the best way to approach this. And we're not going to do it in our last 15 minutes. So I'm going to stop sharing right here. And since we defined it or gave somewhat of a definition of abnormality, mental illness, mental health, I just want to close up. Does anybody have any questions about how we've defined things today? Um, you can put it in the chat. Thank you, Susanna. Thank you, Dina. You can unmute yourself.
I have a question,
Yeah.
yeah.
Yes, Susanna.
Okay, actually, it's not so much about your lecture, but it's about an assignment. So we have a stress and coping assignment with a second or whatever third party, and I don't, even though I know the whole thing is structured around our lectures and what we're learning, I don't quite feel comfortable taking that stress
I
and
don't feel you.
coping assessment. And I
I
just wonder, will I be penalized? And also because of HIPAA, it is, who knows where it might end up, and it's not really that relevant. The material is relevant, but my personal assessment is not.
Hold on just a second.
And,
Go
and
ahead.
if you see me twice on here, it's because for some reason I cannot fix the audio on my computer, so I have you on the phone as well.
Okay. I'm trying to find it. Motivation. Okay, I see that. I'm not seeing the assignment though.
Yeah, it's under the modules. If you look under the modules,
Hmm.
I'm gonna go up there. Let's see here. I'm gonna minimize this here.
Is it the week 1 and 2 reflection?
No, you're on number 6. It's way down there. It's towards the end. I'm trying to find. I have so many windows open right now because I work on various things at the same time. Let's see here. I am.
Oh,
I gotta go to it. Let's see here. Module. Or not that.
Are you
If you go
talking
to
about the stress and coping assessment under
that's it.
motivation and
That's
emotions?
exactly under E, motivation and emotions. It's an assessment. That's correct.
Okay. Well, there's not actually an assignment tied to that.
Well, when you click on it, it automatically tells you to open a stress and coping assessment in a new window, and then
Uh,
it's like an assignment.
Yeah, it's not an assignment. It's something for just if you want to investigate your own stress.
Mental health
Let me click on that and make just sure. This isn't an assignment. They call it a
assessment.
quiz for some reason. I don't know why, but it's just in case you want to go explore your own stress and coping using a little test, but there's no assignment associated with it.
Yeah, I only take those for work related.
Yeah.
Sometimes you have to do one of those assessments, or like I have a Class A CDL with the hazmat. I can carry explosives. I can understand taking one for that, but otherwise, I
Yeah.
don't. I don't. Mhm.
No, no, that's for personal growth reasons only.
Okie dokie. Thank you.
It would have helped if we would have went over that section, huh?
Well, yeah, but I mean, it deals with some of those issues because, it's the effect of the cause of everything you're talking about. Everything we've learned
Um,
thus far.
mhm. Okay, yeah, don't no assignment associated with it, just self-growth if you want to. So,
Okie dokie. Thank you.
Kara, you have your hand up.
Yes, so I was just thinking about what you're talking about. So like being under the influence and all that can, you're talking about that schizophrenia was temporary.
Oh, I hope you didn't hear that. No, what
Okay.
what substance use can do. So, for example, cocaine and methamphetamine act on the same system that schizophrenia does. So, schizophrenia, if we think of it as a disorder, their brains, when they're going through active symptomology, they're overproducing dopamine, like large amounts of dopamine. Okay, cocaine and methamphetamine have that same effect. So when someone is actively using meth or cocaine, they can have schizophrenic symptoms, but those
Yes, yes.
symptoms won't necessarily last. So,
Okay, yeah,
so
that's
yeah,
that's what I heard then.
yeah,
Okay.
okay,
I just
yeah.
wanted to clarify that. Thank you.
No, thank you for clarifying. Okay, thank you.
You're welcome.
Excuse me, I have another question, and I cannot raise my hand because my system's here messed up. But it's piggybacking on what Kara just said. Uh, and I hope you can hear me. Can you hear me?
Yes.
Okay, so if a person used any type of stuff like cocaine or crack or something, and even if they are rehabilitated, will those symptoms still come into play? I'm sorry about my dog. Come into play as time progresses, as they age, because there's effects of using drugs for so many years.
Well, Susanna, I'm going to leave a very vague answer for that. Is it really all depends on a lot of factors with the individual, the amount of use, family history, and genetics that really determine the long-term effects of substance use on the individual. So I hate to leave it kind of as a short answer that's kind of vague, but it really is dependent upon the person and their ability to recover from it. And it's really more of an individual thing.
Thank you. I was just curious because I do have a tenant who's going on 70, and I see some issues and some changes because he's been with me for 2 years. He's rented for me 2 years, and he is a former crack addict.
Uh, and to Dina's question, and then we're going to get to Harold and Leanna, to Dina's comment.
Um,
That
Dr. Peterson, I can wait. Harold and Iana have been waiting.
okay. All right. I'll get to yours in just a second, your comment. Harold, what's up, my friend?
Yes, with the content that you'll be covering, you mentioned the DSM-5. I